Good afternoon. I'd like to welcome everybody that's online for our Wednesday webinar. The SRNA is very excited today to have Dr. Peter Butt. He's a physician and a provincial addictions expert, and he's going to be talking to us today about the use of methadone and Suboxone in clients with addictions, as well as a little bit about the opioids and the opioid crisis. And this is one of the strategies that the SRNA is working with other key stakeholders like physicians in trying to get some information out to RNNPs, RNAAPs, as well as other healthcare providers. And it's also to let you know that the SRNA is working on a regulatory framework for nurse practitioners to be able to prescribe methadone and Suboxone is one of the strategies that we are working provincially with the ministry and key stakeholders as a strategy in addressing the opioid crisis. This webinar will be recorded, and we know that we've got lots of nurse practitioners, RNs, other healthcare providers that will be interested in this in the future. And just to put a little plug in, last week we did have a pharmacist speak about naloxone and harm reduction, and that's recorded on the website. And a reminder for next week that we'll have a nurse practitioner, Mike McFadden, speaking about prescribing in the elderly. So Terry has just a couple quick polls for us regarding what's your designation. So she's going to pull this up just so we know who's online. You can't, with these type of webinars, you can't actually speak live with us, but there is a chat box. So if you have a question or you're having problems hearing something or you can't see something, let us know. Terry Belcourt's with us. She's an RN and a nursing advisor here at the SRNA, and she works with our Education and Learn program and our workplace rep educators. So we had lots register, but we're not sure if everybody's on yet. If you can please indicate your professional designation. We try not to leave anyone out, but we know that we often have other healthcare providers. So if you don't fit into one of those categories, let us know, and we will. And if you can put a chat in to let us know what's your designation. We'll just give a couple of minutes for that to be completed.
We've got 2 of 3
okay.
That have said right now. Lots of times people join in as we go along.
Yeah.
But we can just...
Yeah, sure.
And so we've got 2 RNs on, and neither one of them currently work with patients who prescribe.
Okay, neither one? Oh, good. We've got some new folks, and we know that we'll have a lot of people view this later. Often some folks just can't work around the timing of a webinar. So I'll turn it over to Dr. Butt. We're really happy to have him here today and share his knowledge and wisdom in working with clients with addictions.
Well, thank you very much. I trust that the sound is good and you're able to see the screen. What I want to do is to present to you today on methadone and buprenorphine combined with naloxone. The trade name is Suboxone, which some of you may be more familiar with, but methadone and buprenorphine in care. I'd like to explore addiction in the continuum of care so we can contextualize what it is that we're actually treating when we're talking about opioid use disorders, provide you with information about methadone and buprenorphine so you can better understand their role in the treatment of an opioid use disorder, and explore methadone and buprenorphine's utility and limitations so that we have a good handle on what it can do, how it works as a tool in the toolbox, but also what else we need in order to provide good comprehensive care. Let's start with the case of KR, who's a 52-year-old man, has a long-term history of predominantly opioid IV drug use. However, more recently and concurrently, he's using cocaine, either snorted, smoked, or injected. He's both HIV and hepatitis C positive, but has yet to engage in treatment. He was stabilized on methadone for his opioid use, but his partner continued to use stimulants and his life was rather chaotic. He was attacked on the street, beaten, and admitted to hospital with a head injury and compound fracture. That should be fracture of the right leg. He received an open reduction in internal fixation, but was slow to recover his mental function. As a result, there was a neurocognitive assessment done that found HIV encephalopathy. He was immediately initiated on antiretroviral therapy, gradually improved, but was unable to function independently due to cognitive impairment. This would be a combination of the acquired brain injury and the HIV. He was therefore admitted to a care home. So clearly there are a number of complex care issues that we would have to think about in a situation like this. One would be the management of his neurocognitive deficits. The other would be the ongoing treatment of his HIV, potentially his hepatitis C, the management of his addiction, and of course the nature of his relationship. So this isn't something that we could do quite easily without understanding what his substance use disorder is about. We frequently use the term addiction. It's commonly used, but also commonly misunderstood. The American and Canadian Societies of Addiction Medicine define addiction as a primary chronic disease of brain reward, motivation, memory, and related circuitry. So embedded in the brain, but not necessarily in a way that's obvious to people, like a paraplegia or a hemiplegia or dysarthria. This is reflected in behavior. Dysfunction in these areas leads to characteristic biological, psychological, social, and spiritual manifestations. And I think we can understand the biopsychosocial approaches. The spiritual one is somewhat novel for medical societies. And essentially what we're looking at is a pattern where people become divorced from the essentials of life, the relational nature of life. The things that we tend to value in terms of our day-to-day function as human beings, as herd animals, if you will, as social animals, tends to get sacrificed to the constant search for drugs or other process addictions. So this is reflected in the individual pathologically pursuing reward and or relief by substance use and other behaviors. This definition includes gambling, internet porn, and other process addictions. It's not simply about drugs and alcohol or the chemical addictions, but it's that pathological pursuit of reward that's problematic. And it creates a conundrum, it's a paradox. Within this definition, the characteristics are defined as the inability to consistently abstain. So this would include the individual who does well until they get their paycheck each month, then they binge heavily until they're broke, and then they're reduced to very limited circumstances until they get paid again. Impaired behavioral control is something that we frequently see, particularly in primary care and emergency departments. Craving can be quite overwhelming and hard for some people to appreciate. Diminished recognition of problems with one's behavior in relationships. This would be the denial that we frequently talk about with regards to addiction. And dysfunctional emotional response, that need for immediate gratification, the anger and irritability, the confrontational approach. These are typical of the state that people will be in if they have a substance use disorder. Unfortunately, they tend to get confused as the traits that people have as human beings. Once they get into recovery, once the substance use disorder is put into remission, you begin to see what the real person is like. So the trait-based behaviors, the denial, the lack of recognition of problems of their behavior, the impaired behavioral control, the dysfunctional emotional response, as those abate, you then begin to see what the true traits of the individual are. And that can be quite rewarding in terms of working with this population. Like other chronic diseases, there are cycles of relapse and remission. So we have to plan for relapse. People may be in remission for a sustained period of time, but just like the smoker who hasn't had a cigarette for 5 years, they might light up one day and be back to a pack a day the next, and completely overwhelmed by how quickly it can change. Fundamentally, without treatment or engagement in recovery activities, addiction is progressive and can result in disability or premature death. And we're certainly seeing that. Being the province with the highest rate of HIV in the country, and with a significant number of people progressing from HIV to AIDS, and in fact dying when medication is available to them. But because of the psychosocial spiritual chaos, they tend to be hiding in care's way, if you will. So if we distill down the salient features, what we're looking at is impaired control, compulsive use, and continued use despite negative consequences. So if that's the pattern that you're seeing, you're probably dealing with a substance use disorder. I should also mention here that with regards to process addictions like gambling, internet porn, sex, and so on, you'll see the same sort of salient features. So there are a number of definitions, but in the lay press, if you will, but this is a particularly good one, a pathological relationship with a mood-altering activity and life-damaging consequences. And that comes from Bradford, who's written a lot of recovery literature in this area. And it includes, of course, when you look at it, not only substances, but also process addiction, anything that's mood-altering in its nature. So what causes addiction? What are we dealing with in terms of the primary risk factors? It's important to keep in mind there's no one group that has a monopoly on addiction on one hand, nor any group that is entirely free of it. Typically, we look at a perfect storm, but some of these in and of themselves may be sufficient to trigger a substance use disorder. When we look at the biology or genes, there are certainly genetic components to addiction that have been identified, particularly with alcohol and cocaine, because those are the ones that have been studied most extensively. Gender also plays a role. When one looks at the increased vulnerability of women to alcohol because of a relative decrease in alcohol dehydrogenase compared to men, they don't metabolize alcohol as quickly, it stays in the blood longer, so they become intoxicated at a lower dose. This is also compounded by a decrease in lean body mass compared to men. And quite frankly, an increased vulnerability to trauma, particularly sexual trauma. Mental health disorders are common. Anywhere from 30 to 50% of people presenting for treatment will have a concurrent mental illness. This may be substance-induced, or it might be something that was either pre-existing or something that evolved during the time that they were using. Sometimes hard to tease out, but concurrent care is imperative. And typically what we see are mood and anxiety disorders. The environment is also important, particularly chaos in the home. Adverse childhood experiences have been shown to increase the risk of the development of a substance use disorder later on in life. The influence of parents' attitude plays a role. Peer influences, particularly during adolescence, can be significant, as well as community and school achievement. Keep in mind that in adolescence, we typically see the initial use of substance use and the development of a substance use disorder. The Canadian Society, the Canadian Centre for Substance Misuse and Addiction, CCSA, it did a life and recovery survey this past year, and people in recovery identified first use on average at the age of 13, with development of the substance use disorder retrospectively by the age of 18. So when we're talking about addiction, we're talking about pediatric onset of disease and an important time for intervention. Obviously, a person isn't going to develop a substance use disorder if they don't use. So drug exposure is important. And by drug, I also include alcohol here. So earlier use, wider availability, decreased cost, a route of administration that's more in a binge pattern, as well as the effect of the drug itself, all interplays with underlying brain mechanisms which could be vulnerable because of early childhood trauma or because of the genetics of the individual, and then trigger the addiction. So lifetime prevalence is 5 to 10% in the general population in terms of the development of a substance use disorder. This is another way of presenting the same information. One way of characterizing the genetics and neurobiology is as a fault line within the brain that's inherited, pressure points, if you will. If you combine toxic stress, environmental and developmental challenges that are part of the epigenetics, then that places increased pressure on those fault lines. couple that with exposure and a pattern of persistent conditioning, and here you see the individual binge drinking alcohol, then you've got a perfect storm. But any one of these would be sufficient to, in a vulnerable situation, for a person to develop an addiction. You'll also see in this particular slide at the bottom, the man in the background. And the question one has to raise, particularly when one applies a gender lens, is that man there to watch her back, or is he a predator? And what are the implications for that when people are vulnerable? The other, from a public policy point of view, is the impact on families in our community and the children who end up in care as a result of parental problems with substance use disorder. And in the 2012 Saskatchewan Children in Care report, 49% of the caregivers, this would be the parents or whoever was providing care to the children that ended up under the ministry's auspices, 49% had problems with alcohol abuse, 31% with drugs or solvents. That would be obviously a total of 80%, although some of these would be combined, and 27% of caregivers had concurrent mental health issues. So clearly, when we're dealing with children and families that are impacted by substance use disorders, we have to ask ourselves, are we really addressing the mental health and addiction issues in family already identified as at high risk? Is the more that we can be done from a therapeutic perspective to help families that are struggling with this? Perhaps it's a reflection of other stressors and historical or other trauma within the family system, or perhaps it's simply a reflection of the socioeconomic determinants of health. But there's more that we can do upstream to intervene at family levels when clearly we've identified in our community people who are already struggling. Why is addiction so powerful? Well, as I mentioned, by definition, addiction is seated in the brain. And the question is, what leads to such overwhelming problematic behavior? In this cartoon, you see the mesolimbic area of the brain, more centrally, the nucleus accumbens and the ventral tegmental areas in that pleasure area of the brain that are impacted by substances. So they may be GABA mediated, or they may affect receptors directly, but the most common neurotransmitter is dopamine, although glutamate and others may play a role. But it stimulates common pleasure pathways, and then you can see the arrow reflecting forward to the prefrontal cortex, which is the area of executive function. So as the pleasure area gets taken over by the substances, increasingly the executive function gets influenced and the person becomes more focused on going out, getting the drugs, using, recovering, and repeating the cycle. This also explains why there's often polysubstance use. People may not be purely an alcoholic. They might combine it with benzodiazepines or opioids. People using opioids may combine them with stimulants such as cocaine or methamphetamine, and clearly nicotine plays a role as well. When we look at the reward system and the dopamine levels, this has a functional aspect to the perseverance of the species. Pleasures derived from eating. You see it goes from a basal level of 100 up to 150. This would be the pleasure experienced by a rat eating alfalfa pellets, I suppose. But it's still a significant rise. When we compare that to sex, again, male rats responding to female rats, it's doubling from 100 to 200. And that's a significant change. However, when you compare that to substances, and keep in mind that orgasmic level at 200, we see amphetamines bursting out at 1,000. So this is highly reinforcing. And in fact, with amphetamines, 10% of people on first-time use will become addicted. Rather than 5 to 10% over a lifetime, 10% will become addicted on first-time use. Now, this isn't 100%, it's 10%. Nevertheless, it is significant, and you can see why it would be so reinforcing. So that would be 5 times orgasm. Cocaine is significant, coming in at 3 to 350 in terms of the rise of dopamine. It obviously lasts longer. You can see up to 3 hours before it really starts tapering off. Well, 2 to 3 hours anyway, and can last for as long as 5. You compare that to opioids directly below it, a morphine model. Again, depending upon the dose, there's a dose response curve there. And you see that although it's up to 200, not as high as cocaine or the stimulants in general, it again has a long period of action. Nicotine is interesting, and as you see, it's from a dopamine perspective, as much, if not more, reinforcing than morphine. In a situation like that, one shouldn't be surprised at how difficult it is for people to quit smoking. There's clearly pleasure derived from it. So what happens? Well, as people begin to use more and more, there's progression from perhaps low-level use to abuse to addiction. There's loss of normal reward and motivational systems as drug use takes over. Everything becomes increasingly drug-focused. It becomes harder and harder for the person to feel high or euphoric, and then one is simply using to try to feel normal and avoid depression or withdrawal. And we can see this in this chart, where with persistent use, the development of tolerance, it becomes harder and harder for a person to get high, and then in time to even feel normal. And when I see people coming into my practice in the opioid agonist therapy program of the Saskatoon Health Region, they're often sick and tired of being sick and tired. They've had quite enough of their use, and they want help to move on. A young woman that I saw yesterday, for example, had buried 6 friends because of fentanyl use. And she obviously was at very high risk of ending up with premature mortality. In this PET imaging scan, you'll see the dopamine area of the brain centrally on both sides of the hemispheres lighting up as red, orange in color. That's the healthy control on the left. On the right, you see downregulation of that dopamine system in the methamphetamine user. Now, this person, when they're not being stimulated with their methamphetamine, would be relatively hypodopaminergic, which means that it would be hard for them to feel pleasure. They'd be dysphoric, they'd be angry, irritable, pacing, not at all themselves, and often challenging to engage because they know exactly what they need to take in order to feel better. Unfortunately, it reinforces the cycle of use. So when we look at it from a neuroscience of addiction perspective, we may be looking at a brain disease that's a form of acquired brain injury, a chemically mediated acquired brain injury with disruption of the reward and motivation centers and irrational thought patterns and behavior. So there's complexity to this as well, not only in terms of the neuroscience, but also the chaos of use. So obviously there are multiple drugs and multiple sorts of routes, snorting, injecting, and taking orally, and different types of substances. We talk about the downs or the depressants, the opioids, the benzodiazepines, and alcohol. And these may also be combined with other prescription drugs such as gabapentin, antihistamines, and tranquilizers. Uppers or stimulants commonly seen in our community is methylphenidate, cocaine, and methamphetamine. They may be combined, or they might take one to take the edge off the other. There are frequently speedballs, a combination of an opioid and a stimulant used to get the immediate high from the stimulant, but the more sustained but different euphoria given by the opioid. But there's also typically psychosocial chaos. So these individuals may be street and or gang involved. They may be homeless. There may be disrupted education or vocational training. There's often legal consequences from crime or sex trade work to obtain drugs. Excuse me. Typically also personal growth and development is disrupted. So they may come across as somewhat immature and childlike, or perhaps more like an adolescent in need of immediate gratification. And because of the psychosocial problems, highly marginalized and stigmatized. Having said that, a lot of the kids coming in with fentanyl problems are coming from more middle-class family settings with very concerned and involved parents. Frequently, there's concurrent health issues, including mental health, as I mentioned before, most commonly mood or anxiety disorders, as well as a history of trauma. But then there may be bloodborne infections, such as KR, with HIV, hepatitis C, and AIDS. Frequently, we see people with superficial abscesses from IV drug use, perhaps infective endocarditis that may indeed be fatal, lung, bone, joint, or nervous system infections or abscesses, and perhaps deep pelvic abscesses. Some of these are maybe difficult to diagnose, may present atypically, and of course, the person may be simply seen as drug seeking and written off and not properly investigated. It's not uncommon for them to have several visits to the emergency department before the diagnosis is made. This may be compounded by poor nutrition and suboptimal care. Many do not have good primary care whatsoever. So what is it that we can offer these individuals? Well, most times we think that there's a linear progression from misuse to abuse to addiction, and then they get into detox and recovery and everything's fine. But in fact, what frequently happens is that there's initial engagement with harm reduction strategies, which is a form of outreach and engagement right into the using community with the hope that they can be brought along into treatment. This may or may not include detox, which is what I'll comment on next. Because detox is not treatment, it addresses the acute withdrawal. After the drug or the chemical has been removed from the body, post-acute withdrawal may occur, which can be sustained. And that's the brain going back to normal, which can take weeks or months. So there's often that need for supportive transition from detox to treatment. An important thing to remember is that in opioid addiction, there's loss of tolerance in detox, as well as during incarceration. So this leads to a higher risk of relapse-associated overdose and death. So the standard of care is not detox for an opioid use disorder, but rather fairly immediate institution of opioid agonist therapy in the form of buprenorphine or methadone. So I'm sure you were wondering when I was going to get to that point. And here's a slide, the same slide that I showed you before with regards to the downregulation of the dopamine system. Those receptors have to go back to normal. The drug can be removed from the body, but the brain still has to recover. And during that period of time, they're at very high risk of relapse. So what are we aiming for with regards to treatment? Well, we're looking for improvement in all spheres, that biopsychosocial, spiritual domain that addiction impacts, with progression to an optimal level of function and health. And frequently, because these individuals have come in with significant impact during adolescence, we really don't know what their true adult potential is. So it's important to support them in that transition back to school, for completing high school, getting into post-secondary training, and hopefully getting into the workforce. The sooner the intervention is done, the better the prognosis. With regards to the elements of treatment, there may be simply supportive maturation for adolescents, variations on a matrix model, which would include a number of elements, concurrent integrated therapy for mental health problems, medication, pharmacotherapy, or medication-assisted treatment, as we call it, and then, of course, integrated follow-up. This is a chronic disease. It's best managed in a primary care model. The original matrix model was a 16-week non-residential psychosocial approach using a manual. A lot of these elements were compressed down into 28 days because that's what American health insurance companies would fund. But the original model, which has evidence behind it, is 4 months in duration, which really helps with that post-acute withdrawal transition and helps people with the knowledge translation from the program out into their lived space, into their families, into their homes, so they can really develop the necessary skills to be successful It's hard to do when you're in the cocoon of a treatment center. There's individual counseling, CBT, motivational interviewing, family education is often incorporated, urine drug testing, 12-step programs, and concurrent mental health care, all wrapped around this process. So it's quite comprehensive. What about medications for drugs? Well, with regards to alcohol, disulfiram can be compounded, but it's not commonly used these days. Naltrexone and acamprosate, as of July 1, were put on the provincial formulary. So these are really important ones to have available in a primary care model of treatment, or as part of a rapid access to addiction medicine model attached to the emergency departments. We could have a significant impact on the alcoholism that's affecting our families and communities by using these medications that are now on the formulary. You're quite familiar, I'm sure, with the medication available for tobacco, nicotine replacement therapy, bupropion, varenicline are the most common ones, as well as nortriptyline. Opioids, methadone, buprenorphine are the two most commonly used. Naltrexone is mentioned here, but isn't as effective as the first two when it comes to opioid agonist therapy. Naltrexone is an opioid antagonist, heavily marketed in the States as a depot injection, but it actually works much better for alcohol than it does for opioids. Stimulants, unfortunately, we don't have pharmacotherapy for that quite yet. So let's focus on opioid use disorder more specifically and the role of methadone and buprenorphine in treatment. Again, as you've heard from the previous comments, this would just be one tool in the toolbox. Pharmacotherapy is medication-assisted therapy to help individuals get stabilized enough that they can participate in putting back together a life worth living. So again, we'll be looking at the impact on opioid use disorder. It could be opiates, which are directly derived from the poppy plant, or opioids that are synthesized, that have the exact same characteristics and stimulation of the opioid receptors. Methadone and buprenorphine can be used for pain. Methadone in particular, most commonly in palliative care or chronic pain. They can be both used for addictions, specifically opiate or opioid addiction, and they can be used in individuals who struggle with both pain and addiction, a much more complex care situation. Methadone was synthetically developed by the Germans around the Second World War as an analgesic, as a pain reliever, because they were gearing up for battle and knew that if they didn't have access to opium to the east, they would need to have another substance to be able to treat their wounded. It went out of favor after the Second World War, but resurfaced in Canada and the United States as a treatment for heroin addiction in the 1960s, in part because it has a long half-life, 24 to 36 hours, which permitted daily dosing. The therapeutic range is 60 to 120 milligrams. Now, this is important because it's somewhat tricky to initiate individuals. People will start to overdose if they're methadone naive at around 40 milligrams. So you need to help the individual build up tolerance so that they don't have adverse effects or poisoning during the induction phase, in order to get them up to the therapeutic window of 60 to 120 milligrams. It has very strong affinity for opioid receptors. It blocks opioid intoxication, stabilizes withdrawal, and permits engagement in recovery-related activity. It has to be appropriately dosed, however. If the individual is nodding off purely because of their methadone, then clearly they can't engage. So good feedback, collateral information is helpful in terms of finding the right dose. It can't be determined by blood levels. Happily, we also have buprenorphine and naloxone on the provincial formulary as of July 1. It's a newer combination of buprenorphine, which again is a synthetic long-acting opioid like methadone, but in this case it's combined with naloxone, the antidote, an opioid antagonist, in order to make it safer in case somebody might inject it. It has a plateau in terms of its function, so there's decreased respiratory depression, which decreases the likelihood of overdose, and with the naloxone component is less likely to be injected, although it can be abused, as can methadone. It also has a long half-life that permits daily, or even in some situations every other day, dosing. Typically people are anywhere from 4 to 24 milligrams. There's some times one will see people going up as high as 30 milligrams, but typically 24 milligrams is considered to be the maximum dose. It's applied or given sublingually under the tongue with longer stays in the pharmacy required to ensure that it's dissolved and absorbed. Otherwise, people may leave the pharmacy, spit it out, and sell it as part of their diversion. So what are the limitations of both of these opioids that are used for the treatment of opioid use disorder? Well, they only blockade opioids. They have no impact on other substances such as alcohol or stimulants. And again, they are simply tools, one aspect of care and treatment. They can provide that physical, mental, and emotional stabilization with potential for progression in treatment and recovery. Creates opportunities for improved housing, income, education, vocational training, work, and childcare, and decreases mortality, most significantly. Once people are stabilized, and if the opioid withdrawal during the transition phase is managed, you can get fairly rapid termination of opioid IV drug use. It therefore would decrease needle-transmitted infectious diseases and also decreases drug-related crime in our communities, particularly property crime, robberies, sex trade work, trafficking, and assaults, and obviously would also decrease incarceration. It has a particularly functional interface with the treatment of HIV because the antiretroviral therapy can be delivered even to people who are relatively unstable through direct observed therapy at the pharmacy. So as long as the individual can get to the pharmacy each day and take their antiretroviral therapy for their HIV, we can get reduction in both individual and community HIV viral load and increase their CD4 count. So again, if that viral load is undetectable, even if they were to share a needle, they would not be spreading their HIV through IV drug use. This is extremely important when we're looking at it through the lens of community viral load. Urine drug screens are an important part of the system of care. They're ideally witnessed and done randomly. Most are done on site at the time of the appointment with the temperature taken when the patient is seen for a review and another prescription. The results are typically used therapeutically to address triggers in the need for change. It isn't surprising that people who struggle with a substance use disorder use substances. It may be no longer opioids, but they might start shifting over more towards stimulants or alcohol or benzodiazepines or gabapentin. So clearly one needs to continue to engage these individuals in treatment, in therapy, to help them to address those things that trigger their ongoing use, their stressors, perhaps their concurrent mental illness, the people that they're associating with exposure to triggers such as paraphernalia or places where they've used in the past, as well as obviously the drug itself. But at any rate, if they're continuing to use opioids, that would be an indication to increase the dose of the buprenorphine or methadone. Also, it would determine whether or not they would have access to take-home doses such as carries. Carries require 3 months of good urine drug screens and the maintenance of negative urine drug screens. It may be extended as well, however, by the pharmacy for the pharmacy closure. So people may get carries if the pharmacy is not open on a Sunday or if it's closed on a statutory holiday. Individuals require a lockbox to protect their carries, and they'll progress from maybe 1 or 2 a week or 1 every other day to witnessing 1 day per week only and carrying 6. And again, this depends upon their engagement in recovery activity, not simply the cessation of drug use. So what we want to see are people moving on, getting better, doing better, and then we would step back in terms of the requirements of the program. But it's also about moving forward. It's not just removing the problematic substance use, it's also helping them to put together a life worth living without using, a life that has meaning and purpose for them. So the longer the treatment and support, the better the outcome. Severe addiction requires a chronic disease management approach. This is best done integrated in primary care through primary care providers. Recovery, typically defined as the return of lost function, but as I mentioned previously, some of these individuals really haven't had an opportunity to achieve optimal health and function. So a very gratifying part of this work is seeing how well people do once they establish some traction in recovery and move forward in terms of a life worth living without using. What you see here is the return to normal function in the PET scan from the healthy control to the active methamphetamine user. This is 1 month abstinence. You can see some subtle changes there to a return in terms of the dopamine receptors and system with 12 to 14 months of abstinence. Clearly, it takes time for these changes to occur, and they need support during this period of time, particularly the first 1 to 2 years can be significant. So the factors supporting recovery typically is the ability for them to get support from non-users. Often during use, they're embedded in a drug-using milieu, which is highly problematic, and it's sometimes challenging for them to step away from a social milieu of use and try to re-engage with normal people, so-called normal people. There's often a gap there, and that gap can be filled by contact with the pharmacist, for instance, with healthcare providers, particularly through their clinics or programs, and in primary care. It's important that they take the time that they've used each and every day to go out, get the money, get the drug, use, recover, and get ready for the next day, 365 days of the year, to fill that time more constructively by spending their efforts on family activities such as childcare, going back to school, getting an education, vocational training, going back to work, or in some way giving back to their community. It's important that they learn how to nurture and maintain a healthy connection with others and with life, because that's often disrupted during their period of use. And they've often burned bridges with people around them. Loss of trust, loss of close relationships are very common, and they may be socially very isolated, which is one of the benefits that 12-step recovery communities offer. They're people with lived experience that can support one another in recovery, knowing how challenging it can be. So if we return to KR and quickly review his case, unchanged in this slide from his presentation and his trauma, his concurrent HIV and hepatitis C, as well as his use of opioids and stimulants. We see him admitted to a care home in order to address his neurocognitive deficits. And it's important to appreciate that he may have settled well in the environment of the hospital with prolonged abstinence, but would need to become stabilized in order to prevent relapse on either methadone or buprenorphine. Unfortunately, his girlfriend became a more frequent visitor, and he ended up slipping with methamphetamine, became hyperactive, inappropriate, and delusional. So it then becomes a problem, and he would become more reclusive and suspicious when he was not using. Some of this might be the paranoia, the stimulant-acquired psychosis. Some of it might be simply concern with regards to who his girlfriend is and who her her associates are. And managing this, particularly in a care setting, might be challenging. It would be important to have him stabilized on opioid agonist therapy for his opioid use disorder, to look at how his finances are being managed, the social environment, as well as supporting him in other recovery activities. So the anti-craving medication would be important. Financial management, so he has less money in order to buy drugs, might be helpful. One has to respect his human rights, however, but it is challenging if he has an acquired brain injury. Substance access is something that might be able to be managed in his environment to a certain degree, but I think we would be delusional to think that it could be completely controlled. Certainly that's not the case in corrections. And we also need to establish an action threshold. If he's in a care home, for instance, at this point, what are they going to be able to manage or tolerate? Is there a low, medium, or high level of tolerance in that care home? Because we have to plan for relapse, that should be in the care plan, so that when his behavior is problematic and reaches that action threshold, he can be taken out, placed in detox, at least until he's stabilized, continued on his opioid agonist therapy, but stabilize him in terms of his stimulant use so he can return back to his care home without losing his housing. These are individuals that are at high risk of losing their housing, and then they end up on the bottom of a list and may be homeless and lost to care. So we need to be comprehensive in our case management and our care plans, include relapse as something that it may not be inevitable, but we should plan as if it is inevitable and engage maybe outreach and detox in that action plan in the community. We might also need to look at different types of housing that are better equipped to deal with people with concurrent mental health and addiction disorders. Or if this person was younger, we certainly see people with HIV encephalopathy now in their 20s or 30s, and they're not necessarily appropriate for the type of mental health group homes that we have currently. We may be looking at needing other types of supported living arrangements. So that concludes my presentation. I'd be happy to take questions if anyone should have them. I haven't seen anything come up on a chat box, but that might be on another screen. So questions would be happily entertained. Thank you very much.
Thank you very much, Dr. Butt. It's Terry here, and you're correct. There haven't been any questions on the chat box or through our Q&A, but we do certainly have a few people on. So, you know, to our attendees, please do put forth your questions.
One thing I would like to comment on, though, is the importance, if not really crucial importance, of RNNPs becoming involved in the management of opioid use disorder by being able to prescribe at least buprenorphine and naloxone, and possibly even methadone. We have a shortage of care providers. We need to ramp up the establishment of rapid access to addiction medicine in clinics affiliated with emergency departments so that people can get started on either naltrexone and acamprosate for their alcohol or buprenorphine or methadone for their opioid use disorder. In order to do that initiation, we need to ensure that they can then be referred out into the community for ongoing care. So the more primary care providers that can provide care to this sometimes complex and needy community, in addition to their medication management, would certainly help in this current opioid crisis.
Mm-hmm.
This is Donna here. I just wanted to make a comment, Dr. Butt, and I have listened to you a couple times, and your presentation is always different, and you adapt to what we've asked, so that's awesome. I think for me, it really strikes me that the transition of the complexity of these clients often, and you talked about folks perhaps being in corrections or care home, transition to community at times within their lifespan, they may be homeless, in detox and outreach. And even if you just look at the stress that would put on an individual or a family. I think you really pulled out the impact of those from those individuals, the families, and the communities. And the other thing, certainly what I heard, is often there is that overlap with mental health and other comorbidities such as HIV and Hep C. So these clients really are complex. And I think, you've really pulled out again in the case studies that you've provided, seeing a client that's lost 6 friends with the opioid crisis. Like, to me, that's just astounding, right? Like, that number, and trying to counsel and support them through that. So, I think it's really important that, get this message out to NPs, RNs, and other healthcare providers, and get on the website and get people talking about what the complexities of these clients may be. And they may not be as complex as the ones that you've presented, but often that with the overlap of different use of drugs, it certainly has become very complex, treating substance use disorders. And I was glad to see that you talked about other process disorders as well, having similar patterns.
Right, and certainly nurses have played a significant role in our treatment system, in rehab centers and detox, in shelters, for instance, as well as in mental health and addiction programs. But even if they're not perhaps RNNPs looking at the potential for prescribing buprenorphine or methadone, they play a crucial role in terms of outreach and engagement, in terms of harm reduction strategies, educating people on how to inject naloxone with the take-home naloxone kits, working with that population. The role in shelter care is important, as well as primary care more broadly, because these are issues that aren't going to be resolved in a short period of time. It takes a lot of work. It takes a multidisciplinary team approach in order to help people get stabilized so that their complex care needs, and even their really just very basic primary care needs, can be managed. The other role, of course, is even with regards to care homes. And the reason I used that particular example was because there are a number of nurses involved with that population already. And frequently they struggle with concurrent mental health and addiction issues. But I think that one can sit down and kind of parse out what the problems are and have a care pathway response for not only what's current, but also when things might go sideways, and just plan for it. So it doesn't have to mean a loss of housing or a loss of contact with care. If these individuals completely relapse and go back to the street, then their lives become very, very chaotic, and they may be lost to care and follow-up for quite some time. And a lot of work is extended in order to re-engage them.
Well, and I think too, you have a good point in that first example of that client actually now becoming involved with acute care with that injury, right? And I know in other presentations that I've heard is that concern, even if a patient is in recovery and they have an acute injury or trauma or motor vehicle accident, is the chance of that relapse coming if they were needing opioids or other medication. So again, like the complexity of all those pieces, and even registered nurses that aren't addiction specialists are always involved in some of those care planning. And so I think it's just really important to know that you can bring other people on board in those multidisciplinary aspects and in sorting some of that out.
Right. I think another sector where nurses are heavily involved and impact is in acute care, where they're providing care on the medical wards, on the surgical wards, with increasing number of people that have been impacted by a substance use disorder. And it's important that we work at developing good care pathways for the management of transitioning people, perhaps through withdrawal management or to medication-assisted therapy. If they've been on opioids and they've lost tolerance, they need to have access to a take-home naloxone kit before they're discharged. Similarly, we need to help with these care pathways and both management support, be able to mitigate some of the conflict that occurs at the bedside over medication, over analgesics, over how it's administered and everything else. We need to reduce some of the occupational health and safety stressors that nurses may have in acute care, whilst at the same time ensuring that people that are admitted to hospital have access to evidence-based treatment for their substance use disorder. All too often, it becomes an issue of not only conflict, but a reason for people to be marginalized. So it's not surprising people discharge themselves against medical advice, only to have to be readmitted several times before the underlying infection can be adequately treated. So there's lots more that we can be doing in acute care as well.
Well, and it strikes us too, as we have lots of registered nurses saying that they would like more education in the area of pain management. Because again, how do you tease all those complexities if you don't have a really good understanding of the pain management aspect and what, and then layering on the different complexities.
There's a question here.
Oh, we got a question.
Yeah. So if a client attends for their daily methadone and is observed to be intoxicated either on alcohol or illicit drugs, is it inappropriate for them to take that day's dose?
Yeah, and that's within the pharmacy guidelines. There are standards and guidelines for the prescribing of both methadone and buprenorphine in the province that's archived. I think it's open access on the College of Physicians and Surgeons website, but pharmacists also have guidelines with regards to dispensing. And if a person's overtly intoxicated, they certainly have both the responsibility and the authority to say, you're going to have to come back later, or I won't be able to dispense today and you'll have to return tomorrow. It's surprising how rarely this happens. There's probably more missed doses because of people not coming in as opposed to people being overtly intoxicated. But it does occur, and that's certainly the purview of the pharmacist to address safety in that way. Similarly, they're expected to return all their carry bottles when they come back, and they're to witness a drink and pick up more. They're expected to demonstrate that they have a lockbox. And if the pharmacist alerts the care team to problems with regards to conduct or their alignment with the expectations, then we could have a follow-up conversation with regards to that client, their behavior, and perhaps sometimes either restrict carries, or if it's necessary, they go from one pharmacy to another because they're no longer able to be seen due to their problematic behavior. It's surprising, though, when you think about how chaotic this population can be, how well they do. And I think credit needs to go to the pharmacists and their ongoing conversations. It's a lot of brief intervention, if you will, when they're seeing them on a daily basis. And a lot of pro-social skills are taught. Fundamentally, it's not a good idea to be shoplifting or swearing and creating a ruckus in your community pharmacy that's dispensing your methadone or buprenorphine. You're not likely to be welcome there in the future.
Any other questions, Terry?
Nope, that's all that I see.
So having heard no further questions, we want to thank Dr. Peter Butt for sharing his expertise and sharing some case studies and really demonstrating that complexity. And their needs really do need to be really assessed and individualized treatment plans.
And your contact information is there, Dr. Butt, so if people have questions, they can contact you directly. Is that true?
Yes, that's fine. That's fine. Thank you very much. I appreciate the invitation.
Thank you. Take care.
Thank you.
Thank you. Bye-bye.